The first case of AIDS identified in Kenya came in 1984. In the United States, doctors had noticed odd cases of healthy men developing various types of pneumonia and cancer, more typical of people with compromised immune systems. When more and more cases arose, and it became clear that it was most prevalent in gay men, health officials realized that pneumonia and cancer were secondary diseases caused by something else, something new. By 1984, the international scientific community had identified this disease and called it AIDS, a short form for acquired immune deficiency syndrome. They knew that it could be transmitted sexually, from blood transfusions, from sharing needles, and from mother to child. They knew it was caused by retrovirus and were on the cusp of identifying which one. What they did not know was how to cure it. Hello there and welcome to Scorecard. My name is Victor Nzobeli and I will be your host. The HIV epidemic in Kenya has evolved since the first case was diagnosed in 1984 to become one of the major cases of mortality and has placed tremendous demands on the health system and the economy. The epidemic has affected all sections of society: children, the youth, adults, women, and men. The country's response to this epidemic has also evolved over the years from a health sector-led response to a multi-sectoral one coordinated by one national authority, one strategic framework, and on monitoring and evaluation framework. The response to the epidemic has been improving in tandem with the increase in availability of reliable and comprehensive data, which has enabled the country to sharpen its focus on the key HIV transmission areas and populations in order to reduce infections. HIV prevalence is higher among the general population in urban areas than those in rural areas. However, men in rural areas are more likely to be infected by HIV than men in urban areas, with a comparison of 4.5% to 3.7% respectively. Over time, the HIV prevalence in urban and rural areas has converged, with only a modest difference between the two. While external donor financing and support are critical in the battle against HIV and AIDS, relying solely on donor funds and policy guidance puts the intervention method's identity, autonomy, and mission at risk. External funders have monopolized and dictated the HIV and AIDS conversation in Kenya, particularly in terms of establishing programs and policies, to the point where government initiatives are timid, if not dictated. Kenya's government spends more time negotiating competing donor demands than identifying their own priorities and implementing their own programs as a result of this approach. Every year on 1st December, the world commemorates World AIDS Day. People around the world unite to show support for people living with and affected by HIV and to remember those who lost their lives to AIDS. Data from UNAIDS on the global HIV response reveals that during the last 2 years of COVID-19 and other global crises, progress against the HIV pandemic has faltered, resources have shrunk, and millions of lives are at risk as a result. We have only 8 years left before the 2030 goals of ending AIDS as a global health threat. Economic, social, cultural, and legal inequalities must be addressed as a matter of urgency. In a pandemic, inequalities exacerbate the dangers for everyone. Indeed, the end of AIDS can only be achieved if we tackle the inequalities which drive it. World leaders need to act with bold and accountable leadership. And all of us, everywhere, must do all we can to help tackle inequalities too. In 19 high-burden countries in Africa, dedicated combination prevention programs for adolescent girls and young women are operating in only 40% of the high HIV incidence locations. Only a third of people in key populations discrimination and stigma. According to a new report, HIV infection in the country has increased for the first time in 10 years. The World AIDS Day Report 2022 that was released on Wednesday indicated that the country has recorded an increase in new HIV infections for the first time in a decade, with more than 2,000 cases from 32,025 to 34,540. The report attributes the increase in new infections to the constant new HIV infections among children, adolescents, and younger people, and the shortage of HIV commodities. It also reported that 52% of all new infections occurred among adolescents and young adults aged between 15 and 29 years, with 26% among 30 to 44 years. Infants and children between the ages of 0 to 14 contributed to 15% of all the new infections, with 45 and above contributing to 7% infections. The infection among adolescents has reduced by 171 new infections, from 5,294 new infections in 2020 to 5,123 in 2021. Kenya's new HIV infections are dominant among children and younger adults below the age of 34, while the larger cohort of the people living with HIV is older adults, many of whom might have been infected at a younger age. This is according to the survey. Total AIDS-related deaths in 2021, inclusive of children and adolescents, stood at 22,373, which was an increase from 19,486 recorded in 2000. Half of these deaths were recorded in Nairobi, Kisumu, Homa Bay, Siaya, Migori, Nakuru, and Mombasa, Kakamega, Kiambu, and Kisii counties. Even though other key populations, including female sex workers, men who have sex with men, transgender people, and people who inject drugs, have increased. New HIV infections have reduced from 33% in 2009 to 13% in 2020. This is all thanks to a program that has targeted these key groups for the last decade.